Greetings and a warm welcome to everyone in attendance. I'm Rimpa, your assigned moderator from Planet, and I extend my cordial greetings to all the delegates from across the country. We sincerely appreciate all the doctors who have taken the time to attend the session with us today. Allow me to briefly introduce our platform, Planet. It is India's most trusted live digital CME platform, which allows doctors to create their own medical content. Now, it is my proud privilege to welcome our keynote speaker for today, Dr. Dhanesh Bharadwaj, sir. Sir holds a degree MBBS, DRN, BCTVS, FACC from USA, a skilled cardiothoracic and vascular surgeon. He is a consultant at Medanta, known for his expertise and advance in cardiac and vascular surgical care. And today, sir will be talking on the topic retrocardiac surgery, challenges and solution. Now, without any further delay, sir, I would like to hand over the session to you. Please proceed with your talk. Over to you. And just allow me a moment. Let me just share the slides for you. I hope the slides are visible, sir.
Yeah, slides are visible.
Yes. So just command me next, then I will move forward with the next slide.
So thank you, Rimpa, for the kind invitation, and I am thankful for the clear for this session. So my name is Dr. Dhanesh. As already, I am working in the Medanta Hospital as cardiac surgeon. So today we will talk about the redo cardiac surgery challenges and then its solutions. So next. So as we all know, since the patients nowadays has a longer longevity because of the advanced technologies, advanced surgeries, our daily lifestyle routines, and as the poverty is decreasing and prosperity is increasing among the patients, and so the patients live longer. So if the patient undergoes surgeries at the other stage of life, they may need the redo surgeries, and sometimes there are limitations with our surgical procedures also. When we perform the CABG, the graft tend to last for 15 years or 20 years. After that, some of the grafts got blocked. And the patient look longer, they require second surgery in their lifetime. As like in the valve surgeries also, the biological valve goes, the prosthetic valve degenerations, and sometimes the aortic valve, when we implant the aortic valve, the aortic root got enlarged, and for there is forms of pseudonism also. So that's why and they need the redo surgery in the later part of their life. Likewise, they also develop endocarditis because of the infections and any other reasons, and they require the redo surgeries. So it comprises about 5 to 12% of the total cardiac volumes. As we all aware, the redo surgeries carries the mortality rates higher than compared to the primary surgeries. The primary surgery mortality roughly 1 to 3% of the patients, and the redo carries about 3 times mortality, roughly around 4 to 12%. Next. Next slide, please. So we will discuss in the different sections. So first of all, we will discuss in the section 1 the preoperative risk staging of the patients, as we have, because the risk is comparatively high compared to the primary surgeries. So we need to characterize the patient according to the risk categories, and there are 2 scores we use routinely. Like one is Euro score and one is the STS scores. So Euroscore model 2 we routinely use here, but it will sometimes overestimate the morbidity and morbidity. Next slide, please. Next. So as you see, we just quantified the risk profiles and we have done the preoperative planning. In the routine primary CABGs, the average mortality is roughly range from 1% to 2%, and morbidities range from 6%. And while in the reduced cases, the average mortality roughly between 4.5 to 6% or 7.5, the Euroscore 2, and the morbidity rates are roughly around from 14.5. And likewise, in the redo mitral and double valve procedures, in the primary surgeries, the mortality is around 7.5 to 11.2%, but mortality rates are quite high. It could be around 22%. While performing the arch procedures, it carries the higher mortality compared to the other surgeries, because as the procedure is very high risk. So the mortalities range from the 12% to 21%, and the morbidities lie between 31%. So next, please. So while we perform the redo cardiac surgeries, the multidisciplinary approach is very important because we have to involve both the cardiac surgeons, cardiologist, anesthesiologist, and the radiologist for the appropriate planning. So because this is not a routine simple surgeries, because it carries, and we know the longer, more mortality and more morbidity, and there are a lot of adhesions, and there are patent grafts, the patent valves, and there are also a lot of dense adhesions, so that that's why the higher chance of the morbidity and the mortality. So the heart team, we have to prepare a heart team in every institute. In our institute also, we have a heart team. We discuss among the cardiologist, radiologist, and the cardiac anesthetist, and then we plan the surgery accordingly. And also, we have to keep in mind, because most of the patients are the elderly patients, and they are frail and low body weight. So we have to calculate the frailty index in patients, because as the patient's age increases, the morbidity and the mortality increases. Likewise, in these patients, there are might be chance of the stroke in the post-operative period. So we have to preoperatively, we have to ensure they don't have any neurological dysfunction or the cognitive dysfunctions in the preoperative settings, because of the microembolism, the post-operative period, there might be further decline in the cognitive and neurological status, and we have to take strict clearance from the neurological side. Next, please. So this is the whole source slide for the preoperative planning. So for the preoperative planning, the most important things are the preoperative surgery OT notes, previous surgery OT notes. So because most of the time they are lost, because if the patient came early in the initial 1 or 2 years or 3 years, they might be available to the patients, but most of the time the patient who came later in the life, after 10 years or 15 years, mostly they are lost. But this carries the very importance in the while performing the redo surgeries, because we need to identify the graft configuration in the previous surgeries, cannulation strategies we used in the previous surgeries. Is there any patient here who got the single patch repair or double patch repair, where the patch has been applied on the LV, RV, in the right atrium, left atrium, where it's applied? So we need to know exact location and which material was used for the repair. And also there are some adhesions prone area which are handled most of the time. So the area which is handled most in the previous surgeries, they are more prone for the adhesions. So we have to take care while removing those adhesions. So, and also if any patient has got any previous complications or re-exploration in the previous surgeries, so it should be mentioned in the preoperative notes, so that the surgeon got alert while performing the second surgery. So likewise, we need to also check for the previous echo images or the X-ray image available. For the redo surgery planning, we need to perform the lateral chest X-rays and the CT scan, which is mandatory and gold standard. Also, we need to reconstruct the VRT images, by the virtual reality, for the calculation of the exact dimensions of the aorta, right, all the chambers. Also, we need to check the distance from the sternum to the right ventricle, so that we can plan accordingly. We need the emergency bypass or not. So also we need to check for the Doppler dimensions of the femorals, femoral artery and femoral veins, both, whether they are suitable for the fem bypass or not. Sometimes they are smaller in size, may require the graft also for the enlargement. And so we need to be preemptively aware about these dimensions. So we need to check for the native vessels and any patent grafts by the coronary artery angiography. And we need to check whether any competitive flow is there or not, and while we with the CAG help. Also, in the laboratory investigations, all the culture reports are very important for us. Also, the platelet counts, CBC, and other routine parameters, liver functions are very important. Likewise, the kidney functions. So, also with the T, we need to check for all the dimensions of the chambers, PA pressures, LV ejection fractions, and right ventricle functions. So in the for the planning period planning, we need to check whether we have the near infrared spectroscopy with us or not, because these patients the pump time is very long in few patients, and so sometimes there might be, if we need to check the perfusion of the brain on the both the sides, so whether it's decreasing on the one side or not. So this is very important while performing radio surgeries. So this is others are the routine things like the external defibrillator which is mandatory for the all performing the radio procedures. Blood should be available. We need to check for the 6 unit of the at least PRBC, 6 FMP, and 6 platelets, and then the cryomonitoring sometimes need to be available. So groin should be checked and fully prepared one night before the surgeries, and we need to be CPB ready in case of the emergency if arises. So likewise, from the these things we have the planning, we need to quantify which are the factors, risk factors for the poor outcomes. We can expect the poor outcomes if we need find this. If the patient is very elderly, early function is very poor, PA pressures are very high, pulmonary hypertension already set in, the renal dysfunction is there are multiple previous sternotomies already, and patient is requiring the urgent or emergency surgeries, they are very high risk, and they are high morbidity and mortality in these kind of the patients. Next, please. So apart from that, the other routine preoperative protocols, like to check for the coronary patency, which the coronaries have any conduits if they have applied in the previous surgery are working or not, or whether there are any native artery disease which has developed further after the bypass operations. So by the T, as we will discuss, we need to check the PA pressures, any valve structures, any gradient across the valves, whether which valve are working or which valve are not working. Any shunt pathologies, there is shunt, it will sometimes the ASDs there, PFOs are there, so we need to check for those, and we need to check for the gradients across the valves, and also look for the cannulation sites, previous cannulation site by the echocardiography, and the daring also help in the daring while coming up from the bypass, and also help in the measuring of LVEF. So apart from that, as I will discuss, the Doppler imaging is very necessary for assess for the femoral sizes and to determine the viability of the emergency bypass. Next, please. So as we discussed, the CT scan and the lateral chest X-ray, these are the gold standard things while performing the review surgeries. So we need the CT scan or the VRT images to measure the RV proximity to the sternum. Apart from that, we need to check whether the aorta is dislocated from the midline or not, on the which side it has been dislocated, and we need to check the patent graft locations and the calcification. Apart from that, we need to check for the sternal gap distance from the right ventricle. Ideally, if it's more than 1 centimeter, we are okay. We can perform the retrosternal the ease, and we need to check the lima path from where the lima is crossing, whether it's crossing the line or crossing the sternum, how far is from the sternum, and we need to check by the help of the clips we have applied in the previous surgeries. We need to track those clips and liar clips so that we can track which path lima is taking, and also for to check for the aortic calcification so that we can check whether the coursing aorta, we need to change for our cannulation strategies. We need to go either we need to go with peripheral cannulation or by the center cannulation, and which area is safe for the cannulation. Also, apart from that, sometimes if coursing aorta is there, we need to go for the axillary cannulation in some cases. And if though by the CT scan we can check the risk quantification, and there are some risk factors which we need we need to check on the CT scan whether it's present or not, whether the RV is touching the sternum or not. There is patent lima is crossing the midline, so there is definitely high risk. If ascending aorta has developed the pseudoaneurysm, this is definitely high risk. If there is right atrium is large and densely adherent to the sternum, then it's become very mandatory to go for the peripheral cannulation. Next, please. So definitely these patients are very high risk for the bleeding. So then in these cases, the redo cases, the risk of bleeding arises because of the lot of adhesions. And sometimes the patient have coagulopathy because of the liver dysfunction itself. And sometimes the primary pathology is there, and they have low platelet count sometimes. And they also in the redo cases, the CPU time is longer because we need to sometimes explant the valve, and we need to that remove the adhesion, so that they require the longer time. So we need to check for the blood conservation strategies in these kind of the patients. Cell savers should be strictly used if available with us. We need to routinely use the antifibrotics, and point of care testing should be available with us. Like we need to check for the ACT and INR in these cases. And strictly, if we can, how much low blood we can give, we need to follow that. So to avoid the excessive blood transfusion, so because to avoid the trailing complication in the post-op. So also for the viscoelastic testing, so if we have tag and rotum, that's very good. If because the benefits arise because we can do the goal-directed transfusion in the patients. If they depending upon the deficiency of the factors, whether it's a patient is deficient in the platelets, patient is deficient in the cryo, and whether it needs that coagulation factors, particular coagulation factors, so we need to do that. And also we can decrease the product requirement by the use of these tag and rotum like POCTs. And also we can check whether rotum tracing or tag tracing, whether this factor is deficient in the patients, and we do the goal directed transfusion. And so next please. So also while performing the redo procedures, so the patient specific approach is mandatory. So some patients require different strategy, and some patients require another different pathology strategy. So because I have just mentioned here the two cases, the two scenarios, like if one is scenario of the redo CABG, 64 5-year-old male which has undergone 15 years back previous CABG, and the lima is patent. So but the vein graft has already failed. So what will be the strategy like? The strategy will be different compared to the valve procedures, in which the structural valve degeneration of valves has happened. And if the also we can create another strategy, like the patient underwent mechanical valve in the previous surgery, both TBR and VRM, and it has developed the infective endocarditis now. So I think if the one valve is working well, we need to particularly tackle the another valve only, single valve only. So in that those cases, so we can define our strategy, whether we can do by the MICS route, or we can do the midline route. We can take, if the patient has underwent the replacement by the biological valves, can perform the whether the valve is suitable for the valve TAVI or valve TMVR. So we need to check for those strategies. Likewise, we need to check for whether the patient can go the redo surgery by the MICS route, or is there any role of the robot, the second surgery in the also, and whether we can do the off pump or the on pump interventional or non-interventional ways of treating the diseases. Like if suppose the first surgery the patient has underwent aortic valve replacement, now the patient can put in mitral valve replacement, severely dense mitral valve calcification and mitral annular calcification. Now in some cases, so we have performed our institute one patient like this. So we have done what we have done is we have taken the surgical route, and we have the on pump procedures, which is called Citral, and which is a surgical implantation of that mitral valve by the ballooning method. So we can use that method because there is no space to take our bites. So likewise, every patient should be strategized in a specific way. Strategy can be different, and it can be patient specific approach need to be done in the second substitute. Next, please. So next is how to enter the safely, do the sternotomy so that we can avoid the complications. To there should be no catastrophic hemorrhage in the surgery. So there are methods for that, and we have different protocols for that. So next, please. So we have in the previous section, we have already identified the high risk scenarios which may require the emergency bypass. And also we have learned about the aortic valve calcification, aortic valve aneurysm, aortic valve dissections, which may require we need to change the strategy from that routine that femoral or aortic cannulation to the axillary cannulation sometimes. So we need to check for the axillary aortic cannulation. If there is aneurysm is present, dissection is present, sometimes there is no space or aorta is calcified. So in those cases, we can do by the femoral vein and axillary artery side branch cannulations, and we can establish the CPB. And so we need to be ready for the emergency bypasses in some scenarios. If some catastrophic events happen, some bleeding happens. So for that, we need to be ready. The groin should be prepared, and there should be surgically exposed, and we need to be ready for the emergency bypass scenarios. And also, so there is a preemptive femoral access we can do with the rapid emergency code and guided cannulation in the perfusionist options. There are the multiple ways to perform the cannulations. So depending upon the situations, so we can choose one of them. So, but always, every time we need to be ready for the emergency bypass, and groin should be prepared, and we need to be, we need to be sometimes, depending on the high risk scenarios, we need to expose the groin and also expose the femoral artery and femoral veins, and we need to take sometimes first things when we get ready for the bypass if we need it in the emergency scenarios. Next, please. So also, as we used the routine sternal saw in the primary cases, and while performing the redo procedures, we need to do we need to use the prosthetic saw. So we need to prosthetic saw is must mandatory for the redo procedures, and while using the oscillating saw, so this is a step-by-step procedures. First of all, after giving the skin incision, we need to untwist the wires, and we need to hold those wires with the help of those Ellie's forceps or some then the wire holder forceps. And after that, we need to strictly lift the sternal edges while cutting the anterior table of the sternal, and we need to leave behind the posterior cortex and at the lung border so that we not injure the right ventricle. And because while lifting the wires, we have added advantage. We will make sure it does not enter the posterior cortex, and it does not harm the right ventricle or right ventricle or the right atrium. So, and also the aorta. So these are the advantages of the lifting the wires. And we will in the under the vision, we will by the help of the scissors, we can cut the posterior cortex. So we need to be snare under the direct vision. The manual surgical separation of the connective bands to be done, and also the meticulous posterior table dissection of the specialized instruments I will take. We routinely use the scissor for the cutting the posterior table, and also, and so we sometimes you can use the cautery on the low energy cautery. And we use to set around the 20 or 15. You can cut the posterior table, and we can use the continuous epicardial sternal clearance and come to a constantly visual check should be there. Next, please. So even if we use the all preemptive and the precautionary measures, sometimes the breach of the right ventricle happens, and there is a protocol for that to how to manage the breach. Immediately, we need to avoid the blind suturing and strictly and pack that wound. Rapidly initiate the cardiopulmonary bypass by the pre-cannulated femoral lines to unload the ventricles and remove the heart volume. Then after the performing the completing the sternotomy, we need to primary patch repair under the vision of the right ventricle. This is the best way to save the right ventricle. So sometimes while performing the redo sternotomy, the lima graftless happens. So for that, we need to rapidly control the possible distal band after going on the bypass, and maintain the systemic pressure and prepare a fresh saphenous vein graft to bypass the territory. And we need to cool down the heart so that we can decrease the flow. And we need to protect that heart while cooling down so that the energy demand of the heart decreases and we can save the right ventricle and left ventricle. So next, please. So now we will discuss the surgical principle we should follow while performing the redo procedures. So we need to be ready for the CPV before the sternotomies, and these are the strict indications for the CPV before the sternotomies. As we discussed, they are like this in the series: aortic pseudo is there, RV densely adhered to the sternum. There is patent graft which is at the wrist, like the lima or cephallus vein grafts. If there is multiple previous sternotomies, these are the 4 or 5 indications which are the strict for the CPV should be stood first. After that, we will perform the sternotomy. So also while removing the adhesions, so we know the diaphragm surface has the least adhesion, so that surface should be removed first. That we should start from there only, and we should perform the sharp dissections, and we can avoid the blunt dissections by the hand or fingers, and maintain the tissue planes, avoid excessive traction on the tissues over the bleeding, and we should identify the grafts early, and we need to tackle those grafts whether they are working or not. So also these challenges in the surgical principles and surgical techniques arises when we have the patent grafts and patent the working valves, which are normally working. And also because of the redo procedures, there are a lot of collators are already formed, and we have a lot of collateral flows. And also sometimes the left ventricle is also very hypertrophic. So for that we need to strictly protect that ventricle and that hypertrophic ventricle. For that cardioplegia and both antegrade and retrograde methods will be used, and we use the myocardial protection strategies for that. Next, please. So in this section, we will discuss about the myocardial protection, how we can achieve the adequate myocardial protection for the redo procedures. Next. So this is the slide which is comparing all the delivery routes, and when in the primary surgeries how we can do the antegrade method, retrograde method, and the combined strategy. Which is the combined strategy is a gold standard for the redo, and we need to use both, give the cardioplegia by both method, antegrade and the retrograde method, and antegrade by the aortic roots and retrograde by the coronary sinus. And the combined strategy redo while performing the redo procedures, you should do the redo while performing the redo procedure, you do both the antegrade and the retrograde. So there are added advantage of all the procedures. So because the antegrade path, if there is limitation, if there is the AR is there, and also the retrograde path, if the RV protection is poor with the retrograde path, or the antegrade is best. So combined strategy, there is because we need to insert the retrograde cardioplegia cannula, so that the surgical setup time is slightly longer, but it will end up decreasing the time later on because we can perform our surgeries uninterruptedly. So next. So this is basically purely a surgical choice, surgeon's choice. So ideally, the Dalido cardioplegia should be preferred because it gives the cardiac protection for the 90 minutes, and we can do the redo process uninterruptedly. And also, we routinely use the blood cardioplegia St. Thomas 2, which requires the repeated dose up into 20 minutes. Since we have retrograde cardioplegia cannula in this 2, we can give the retrograde method under 20, and we can keep on continuing our surgery. Also, some centers use the custodial cardioplegia, which is offer the continuous protection for the 3 hours, which is mainly useful in the aortic heart surgeries or the heart transplant cases, and the multiple valve replacements are required. Next, please. So now we'll discuss how we'll manage the mammary grafts. So whether if they are working well and some mostly this happens because the lima has higher patency compared to all the venous graft and radial grafts and other grafts. So sometimes, mostly it's patent because of the its added advantage, and we will not discuss with here. So sometimes we need to pre-clamp and to prevent the washout of the cardioplegia. We need to clamp the lima and lima conduits, and so that we can protect the myocardium, and we can avoid the rewarming of the myocardium, that area, particular area, mainly the anterior core of the left ventricle. Also, while dissects of the conduit hilum, which will delicate tissue isolate the first vertebral space, permit the transient occlusion clamp placement to reduce trauma rates, so that we can decrease the flow across the limb. So also we can decrease the temperature while by the ice, putting the ice on the right ventricle and the left ventricle over the target territory where the lima cannot be grabbed because there is no clamping site is available. We need to follow the thermal cooling and the combined cardioplegia technique to tackle the lima. Next. So, as we have discussed, there are also techniques for the while performing, depending upon the surgical time. We need to follow those, and also the surgical type which we are performing. We need to do the hypothermia support and the cerebral perfusion methods. So, if we moderate hypothermia, routinely we use around 28 degrees Celsius, which is ideal for the most routinely used surgeries. And deep hypothermia is required mostly for the bone protection. If there is any patent grafts are there which we can't remove, or there any other problems are there, arch involvement is there, any substant is there, so we need to do the deep hypothermic arrest for the patients. And also we maintain the multiple organ position where aortic clamping hazardous. So these are the advantages of the deep hypothermia. Also, while performing surgery for the aortic arch or any aortic aneurysms or any arch replacement, so we will do this cerebral perfusion, and the selective antegrade cerebral perfusion via the combined branch we can do, or we can do the retrograde perfusion delivery through the vena cava. And as we have discussed, because we can monitor the cerebral oximetry by the NIRS to save the look for the safety of the brain and ensure the safe metabolic targets. Next, please. So in the section 4, we will discuss about the redo CABG strategies, how performant and what are the prerequisites for it. Next. So sometimes what happens is these subnus vein grafts are sometimes blocked, and they are filled with the thrombus, and because they are old and degenerated subnus veins which are very friable, and sometimes the atheromas can dislodge from there. So we need to handle those grafts very carefully, and we need to dissect them fairly, and to avoid the launch of the distal macroemboli provoking the extensive myocardial infarcts. We need to do that. And also, we need to do the target bed identification, whether the fibrous scar which is hiding the coronary territories is complicating blood tracking of the native vessels, where we need to do the bypass grafting. So we need to re-identify, and which often require the visual tracking. While the eyeballing, you can see, you can sometimes feel with our fingers where the coronaries are lying, and sometimes we need to the epicardial ultrasound localization the coronary arteries to look whether where they are lying and where we need to perform the bypass. Next. So for the redo surgeries, sometimes limited choices are available with us. So if the primary surgery, mostly the IMA is already used, and if the surgeon has not used the IMA, then we need to routinely use the IMA, which is gold standard, and which will require around 20 years of patency for the redo surgeries. And if 70% more than 70% is there on the left side, more than 80% on the right side, we can use the renal artery, and which also provide the equal patency rates likewise in the internal thoracic artery. Also, saphenous vein, which is very easily and rapid to harvest, we can use saphenous vein. It's best suited for the emergency situations where the artery conduits is often adjusted. So where they also say we can use this veins. Next. Uh, we now this slide shows the long-term survival trends. As we often know, the mortality is higher in the redo procedures, and also both the curves they are as you can see they are the mortality is higher in the redo procedures, and the patient tend to die early while from the redo, and also the morbidity is also high. And this data is and this slide is taken from the STS adult cardiac database answers review, and which way both the curves are diverging, and you can clearly see the higher mortality along the 15 years in the redo procedure compared to the primary surgery. Next. So in this section, we will discuss about the complex valve reoperations. So likewise, the valve scenarios also I have discussed, whether it's if one we have implanted the one valve in the previous surgery and this got dysfunctional, we need to choose the one valve. Sometimes we do the double valve in the primary surgery and one valve is working well, but is not working well. So in those situations, we need to look for the other alternatives, whether they are available to us or not. So likewise, sometimes there is endocarditis of the one valve and one valve is working well. So though in those cases also, we need to check for the what are the other strategies which are available with us. So we need to the patient should be customized. And every patient specifically require the different strategy compared to the other patients. Next. The redo valve for the as we already discussed, through the redo valve surgical access, aortic root reoperation sometimes required. Because in the redo procedures, the time has passed previous surgeries, there are higher chances of the annular calcifications and the venous formation across the valve and in the aorta. Also, because when we separate the calcium from the aorta and the aortic root, there are high chances of the heart block due to the conduction pathway stress, and there are chances the patient will require permanent pacemakers in the second surgery. And sometimes when you perform the root decalcification, sometimes if the injury happened to the root, sometimes patch reconstruction may be required. Also, likewise, the mitral exposures, the left atrium entry behind this interlateral grooves under the root, we will need to go with the previous incision only, and we need to cut from the same incision line. And sometimes if that area is very densely adhered because of the adhesions, we need, if any scarring is present, we need to change our strategy and we need to go by the transseptal route. And also sometimes the direct debridement of the prostate rings to prevent the tissue tears needed. And also we need to separate the dysfunctional grafts from the mitral side or the aortic side with the help of the spatulas and the other instruments. And we need to make sure we do perform the process with a minimal risk and avoid the excessive injury to the conduction method. Next. So because we have to need to think about the other options also. If the patient has already got the biological valve in the previous surgeries and that valve is compatible for the percutaneous options like transcatheter aortic valve replacement can be performed in those cases. And because these procedures also can give the life of 10 years in some cases, 10 to 15 years they can some last. And also because the patient is very elderly and more comorbidities are there, we can think of those options also. And so by these methods we can decrease the surgical surgery, also decrease the trauma, and also sometimes we can decrease long cuts or the duration of the hospital. Also sometimes, but for these procedures also they require the adequate specific location of the coronary ostia from the aortic planes. So it should be, we need to check by the CT CT TAVI protocol whether their coronary osteas are lying in a particular height or not, whether it's patient is suitable for the TAVI or not. So these are the other prerequisite we need to check before proceeding. Next. So, while performing the redo aortic arch surgeries, so first phase we have discussed in the 4 phases. So first phase is of induction phase. We need to cannulate the axillary artery because there is no space on the aorta, and we need to cover the right axillary artery and the femoral veins and initiate the systemic cooling. We need normally cool till 18 degrees Celsius because we can't apply the cross clamp in the aortic procedures. And we need to establish the DSCA, deep hypothermic circulatory arrest, and achieve temperature of between 18 to 22 degrees Celsius. And in these cases, we need to do the perfuse the brain by the antegrade cerebral perfusion or the retrograde cerebral perfusions. And we safeguard the brain metabolic profiles, and we need to check both by the NIRS whether the perfusion is good or not, whether the brain is perfect or not. So also sometimes the phase 4, we will resect the scarred aortic valve to completely remove that enrichment part, and we will do the any arch reconstruction or elephant trunk, which process is required. So we need to customize accordingly. And sometimes there are something about the replacement or the bed towel is required. So each patient must be customized. Next. So in the next section, we will talk about the patient blood management, because as we are aware, all the redo procedures, there are a lot of chance of the bleeding, and patient will require a lot of not only blood, PRBC, with the patient will also require the other blood products like the platelets, transfusion plasma, cryoprecipitate, individual factors also sometimes required. Also the Trenexa and other things will be required. So next. So we know why these patients are more prone for the bleeding because of the long CPB times, and also lead to the congestion coagulopathy, systemic activation of the complement factors, and also the post-pump dysfunction is also known, and platelet dysfunctions happens, and also there are extensive raw surfaces there, which lead to there are a lot of extensive pericardial fluid adhesions which create a lot of raw surfaces, and which cause diffuse microvascular capillary oozing that require the targeted biological sealant application sometime. Next. So there are some viscoelastic testing protocols. We routinely do the tag at our center. We have tag, and sometimes if the axis bleeding happens, we send the tag, and we need to check for the targeted blood or factors requirement is there, so that we can minimize the blood or glucose requirements. So we score the baseline testing during the blood disease dissection phase to evaluate the coagulation properties early. So while giving the protamine dose, administer the adequate protamine to neutralize circulating heparin, and check for any residual activities they are not by the ACT. And also the target correction should be done depending upon the tag and bottom draws, and directly infuse the fabric concentrate or platelet based on those deficiencies. And also the closure check, perform the sectional closure and the clinical markers with hemostasis and the normal clot strength, and we will need to document those things. Next. So as we know, apart from the blood and the FFP platelet glucose, we need to go to some pharmacotherapy also, or sometimes in these patients. For that, we need some the Trenexa, the platelet factor 4, fibrinogen concentrate, and the desmopressin in some patients, and they are very effective sometimes, and they immediately stop the bleeding. And apart from that, sometimes we need to use the bioglues, and for the over the suture line of the aorta or the left ventricle, so that to avoid the bleeding. So bioglues we routinely use, which is not mentioned here. So bioglues is also important part while performing the redo surgery. Next. So in this section, we will discuss about the clinical outcomes and the matrices. Next. So clinical outcomes and also depend upon the not only the surgery. Sometimes the hybrid approach we need to think, and we need to customize pieces usually. And sometimes if we have hybrid OR, we can perform these procedures from hybrid OR, and we can define a technological convergence, and we can check whether the interventional approach is available for those patients or not. And sometimes we need to check for the whether the patient will is better with the interventional approach or the surgical approach. So we have in our Vedanta we have that complete imaging suite, and which is both which is very instant and safe. Operation can be performed easily, whether patients require the rapid the conversion of from the translational procedure to the open surgery can be performed there, and if any complications happens during the guide and during the international procedure, we can manage surgically there. And also we can optimize the interaction between the cardiologists and the surgical teams, and we can do a better work for the patients, the patient benefit, the hybrid goal. Next. So we have already discussed about the mobility, the redo procedures. So apart from that, we have a lot of morbidities in the redo procedures, and among them, the acute kidney injury is the most common, which comprises around 19%. And there is chance of bleeding, definitely the redo procedure, about 20% of the cases. And also apart from that, there is prolonged ventilation is also required because of the sometimes they have the preoperative COPDs and lung dysfunctions, and they require a prolonged ventilator support, and they require maybe extend beyond the 24 hours also. And also there is higher chances of the stroke and the CVAs in the redo surgeries, which can range from 1% to 6%. Also the reacts is also common because of the bleeding, sometimes which range from the 6 to 9% of the cases. And also they have new onset of the atrial fibrillation, which is quite common after the redo surgeries because of the and which can hamper and which can prevent the early recovery of the patients. Next. So now we have reached till last, and the take-home message from this presentation is so the for the preoperative planning is the most important thing while performing the redo surgeries, and preoperative CT is the gold standard and the mandatory. Apart from that, the lateral chest X is very important to calculate the distance from the right ventricle and the sternal lower sternal border. And also this safe entry determines the outcome. We need to avoid the catastrophic hemorrhage in every cases. And also the peripheral lesson should be visualized accordingly depending on the situations. Also the myocardial protection is very critical to the patients. Also the multidisciplinary planning improve the results. And also as you have discussed the future directions, the redo procedures, each patient should be customized. And also now because this is an era of the AI, artificial intelligence, and also sometimes the patient have any complex pathology or complex congenital pathology, and there we can by the help of the AI or 3D printing we can preoperatively assess the risk, and we can assess the structure of that pathology preoperatively, from where the graft is lying, how far is the distance, how is the dimension. These things can be calculated by the AI planning. Also, the VRT images by the 3D reconstruction of the CT can help in the planning. Also, the patient specific simulations are also there, by which we can preoperatively assess the distance and other things. And also, that interventional approach method should be open for each and every patient. And this is key to the mind whether we are give help to the patient with the interventional method or whether the surgery is the mandatory. So also the robotic surgery and the MICS, they are new in the domain, and which are also beneficial for performing the redo system. Next. So these are the three consensus guidelines and the papers from which this all presentation is made, and we have taken the guidelines from the STS expert consensus between 2022 2026, and that's the paper from the Simon et al., which is presented now in the recent STS meeting. We have taken from that few part, and also the paper by the Puskas et al., which is presented open CABG study in 2026. We have taken some part of the CABG from there. Next. So these are my references from where this presentation is made, and thank you for your patience. Thank you.
Yeah. So thank you so much, sir, for the wonderful talk. The session was really very informative, sir.
Thank you.
Yeah. So just allow me a moment, sir.